My brief was to talk to you about the drivers of HIV transmission in young people and to talk about barriers to HIV prevention, and then to talk about innovations and to reflect really on what was coming out of IAS 2016. And I have to say that 30 minutes is probably going to be a whistle-stop tour, and I probably won't do your particular topic justice, so please forgive me in advance. But this is really just my take on where I think particularly prevention is, and and I will spend a little bit of time talking about adolescent treatment as well. So you will see a variety of this type of slide over the next couple of days, I imagine. But importantly, in terms of where we are in the HIV epidemic at the moment, we have seen some countries that have seen declines in HIV incidence, some where incidence is stabilizing, and some where there are increases. And we haven't managed to achieve as much in terms of preventing HIV infection in adults as we have with pediatric populations. And one group in particular that continues to have high rates of HIV infection are young women. So why do we need to pay attention to adolescents when we think about HIV prevention? Well, in my mind, there are two particular reasons that make this population special. The first is that young people aged 15 to 24 comprise 1/5 of the world's global population, but they account for about 1/3 of new HIV infections in adults globally. So they bear a disproportionate burden of HIV infection. And if we look at young women in particular, they account for about 2/3 of new infections in sub-Saharan Africa. And this is important because this age group is one of the projected to be the fastest growing demographic on the continent by 2050. And so this is a population of increasing in absolute numeric terms of susceptibles to HIV infection. And so if we are to achieve the ambitious UNAIDS targets of reducing HIV infections by 75% by 2020, we really need to intensify our efforts in this population over the next 2.5 years, and then kind of sustain that effort over the next 5 years if we really want to change the trajectory of the HIV epidemic. The second reason why this population is particularly important is because adolescence is a period of enormous transition. This is a period of intense physical, neurocognitive, and social transition. Under the influence of hormones, young people's bodies change and grow, their brains develop, and during that period they develop the neurodevelopmental process means that they have a predisposition towards risk and reward versus executive functioning, which must develop over time. But these changes in the body and the brain become associated with changes in leaving school, leaving home, forming new relationships, and transitioning to adulthood. And interestingly, what we learned from the conference is that in populations of adolescents, young women particularly, that have low executive functioning, so where their executive centers are not fully developed, this is has been seen to be associated with increased risk behaviors and HSV2. So it's a very important period for risk behaviors and reducing harm during this transition to adulthood. So young women in particular in our region are worst affected by HIV. Although Eastern and Southern Africa account for about 6% of the world's population, about half of people living with HIV live in Eastern and Southern Africa, and about 40% of those people live here in South Africa. So interventions in this region are going to be incredibly important if we're going to change the HIV epidemic. This slide is particularly interesting because it has taken what we know about incidence down to the level of the district. And on your left-hand side panel, you can see incidence rates in young women 15 to 19 years old. And the reason to point this out is that if you look in the panel of 20 to 24, we know that incidence is highest in the 15 to 19-year age group. But when we start to think about HIV prevention interventions, we shouldn't just look at these populations in isolation from the rest of the population. While incidence is highest in the 15 to 19-year-olds, in terms of absolute numbers, actually the numbers of new infections are higher in older age groups. And also when we think about who is becoming infected with HIV, we need to look at exactly where they live, whether it's in an urban area, rural area, and also kind of there might be differences in terms of their relationship status. So risk for HIV is not heterogeneous, and we need to customize our HIV prevention programs to the risk profile of that particular context. So why is it that young people, and particularly young women, are so at risk for HIV? Well, we have models to help us understand the relationship between different factors, and there is a hierarchy of factors which suggest that there are immediate biological factors which increase young people's risk, and these are mediated by proximate, generally behavioral factors, but often those factors are shaped by the social context in which those young people are living. And what I'll do is review briefly what we know about those risk factors and then discuss how we put that all together. So we have evidence that sexually transmitted infections, but more generally non-specific genital inflammation, appear to increase the risk of HIV in young women. There is also some evidence that hormonal contraception may increase that risk, and there are a number of male factors which also may increase young women's risk. In terms of the per-act transmission risk, women have a higher risk than men, and the reasons are partly anatomical and physiological in that there is a wider surface area of the female genital tract. HIV virus tends to be concentrated more in semen than in vaginal fluids, and there may be activation of cells that are receptive to HIV in this broad area of the genital tract. One of the factors that upregulates cells that increase HIV susceptibility are sexually transmitted infections, and if you were at IAS, you may have heard some of the discussions about bacterial vaginosis and basically vaginal dysbiosis and how that may predispose young women to HIV, and some meta-analyses have also been able to show that. And we've known for quite a while that herpes simplex virus increases HIV risk by about 2 to 3-fold. But unfortunately, what we haven't had are many interventions that have been effective in addressing those cofactors. So another factor which has received increasing attention over the last few years has been hormonal contraception, and in particular the role of DMPA, injectable contraceptives, in increasing the risk of HIV acquisition. And at IAS, Chelsea Polis and colleagues presented the results from an updated meta-analysis, which included, I think, about 10 additional studies that had been published since their last meta-analysis. And when you look at this slightly blurry graph at the bottom, I think the important point to take away is that there are many dots on this side of the line suggesting an increased risk of HIV acquisition. These are all observational data. These are sort of the better designed prospective studies that have looked at this question. And the conclusion of the authors was that there does appear to be new information which suggests or confirms that DMPA does appear to increase the risk of HIV acquisition in women, and that this is about a 50% increase from women who don't use injectables. But the challenge with this type of data is that prospective cohort studies are still subject to residual confounding. And in particular, people who may use contraceptives may not be as likely to use condoms. And so if we really want to understand the relationship between hormonal contraception and HIV, we need to be able to measure this in a trial. And the ECHO trial is one such trial designed to really provide an estimate of whether or not DMPA or containing contraception increases the risk of HIV. So there are a number of male partner factors. In some areas of southern and eastern Africa, male circumcision prevalence is low, and this has been associated with an increased risk of HIV acquisition. But also in many parts of the region, what we see is that men have been slow to access, HIV positive men have been slow to access treatment services. So we have data that shows that men have lower testing uptake, that they often present significantly later for treatment, and that it's often difficult to retain them in care. And because of this, these partners are likely to have higher viral loads, which would make them more likely to transmit infection. When we look at, so those are important biological factors, but obviously we need behaviors to ensure that those factors are contributing to increased risk of HIV infection. And in young people, there are a number of behaviors that have been identified as increasing their risk for HIV infection. And in fact, these are measures that are used in many national surveys to monitor HIV prevention behaviors. So early sexual debut, age differences in sexual relationships, low condom use, transactional sex, and alcohol abuse. And what we see over the last few years is mixed data, that in some settings we've seen, so this is an example of sexual debut, and here we see between two surveys about 10 or 15 years apart, that there have been some improvements in the age of sexual debut in some countries, but in other countries we've seen declines in the age of sexual debut. And in South Africa, what we saw in the most recent HSRC survey was in fact lower rates of sexual debut, higher rates of multiple partnerships, increased age-disparate partnerships amongst young women, and lower rates of condom use. So sustaining behavior change is challenging, and that's often because behaviors, if we try to change behaviors at an individual level but we don't change the context, it's very difficult for those individuals to change those behaviors, particularly if they're young and at the beginning of their sexual history. So structural factors or underlying factors that shape the context in which sex takes place are incredibly important for shaping the HIV epidemic. And education, poverty and food insecurity, gender inequality, marriage practices, the low social power of adolescents, and access to quality health services have all been identified as important factors that are shaping HIV risk, particularly amongst young women. So we now know that education is protective for HIV. And in a survey that was conducted in South Africa, what we saw is that young women who hadn't completed high school were almost 4 times more likely to be HIV infected compared to those that had completed high school. And 2 recent reviews on HIV and education show the protective association between higher education and HIV infection. And this is something that was not seen early on in the epidemic, but has been confirmed with these later reviews. So importantly, in our setting in the region, we know that poverty pushes many young women, young people out of school. And in South Africa, about 2/3 of young people who weren't in school said that they weren't in school because of the costs associated with education. And this is often in the form of uniforms or transport or other types of supplies. So even when education is free, it does have costs. And these young women will drop out of school in order to find employment, or they may be required to stay at home to look after children or elderly or sick family members. And because of this, young women, poverty really erodes the ability of young people to amass education, access the formal economy, and increase social capital that will get them out of the poverty cycle. And many young people make up about 40% of the unemployed population globally. And in our region, we also see many young people migrating to cities in search of work. And we know that cities are places which are associated with higher HIV prevalences, and so the risk of coming into contact with people who are HIV positive is also much higher. Another important factor that's been associated with HIV acquisition is intimate partner violence, and this is data from a survey done in young people aged 15 to 19 across 5 cities globally. And importantly, on many indices, Johannesburg was one of the worst cities for young people to live. And importantly, in this population, a third of young people already aged 15 to 19 had reported lifetime intimate partner violence. Now, this is normally a measure we see for women who are much older than that. So this is a particularly distressing measure, I think. And what we know from the data is that prospective studies have shown that intimate partner violence is associated with an increased risk of HIV acquisition. And we think that this is through a number of mechanisms, through direct, and that the sexual assault mechanism is not the most important mechanism, but that the factors that cause partners to be violent may also be associated with other risk behaviors, and that there may be other indirect mechanisms which may be increasing young women's stress and potentially changing their immune regulation. So this is a very important factor in our setting that we need to consider. Another item that we've talked about are barriers in access to sexual and reproductive health services. And the consequence of this are that many young people have limited knowledge and don't have access to quality, comprehensive sexuality education in the region. There are also many conflicting laws that govern the age of consent and sexual activity and may require healthcare providers to report sexual activity in underage young people. There are also third-party requirements for consenting of different procedures, for example, HIV testing or access to contraception. And all of this makes access to sexual and reproductive health services much more challenging for young people in this age group. We also find that as a result of this complexity, providers are often the ones interpreting the law, and that is often associated with stigma and discrimination against sexually active young people from key populations, and as a result we see low uptake of preventive services. And another kind of quite practical point is that these services might be inaccessible not just because of stigma and discrimination, but because they're open at the wrong time, they're not near enough to where people live, and young people don't necessarily have access to resources to travel in quite the way that adults do. So these are important considerations. And just a quick note on young key populations. What we know from the literature is that young key populations will have more unprotected sex. They do have higher rates of sexually transmitted infections, including HIV. They are more likely to experience unintended pregnancy and violence, either from partners or clients. And they have higher rates of mental health disorders and substance use problems compared to either older members of the key population or young people in the general population. So young key populations are the most vulnerable of all adolescent populations, and they also have significant barriers to accessing care. And because of this, and because they're a hidden population, there really is very low coverage of services for this population, which is compounded by the stigma and discrimination associated with belonging to a key population, making them a very vulnerable population. So just a comment on what the unavailability of sexual and reproductive health services means for HIV. There was a review a couple of years ago which highlighted the unmet need for contraception amongst adolescents, with unmarried adolescents using between 20 and so 1/5 to 2/3 using contraception, and that unmarried adolescents had a far higher rate of unmet need for contraception. What we know is that pregnancy in this age group is associated with increased complications, and that pregnancy is often unintended or unwanted in this population. And so many young people seek abortion, and those might not be legally available in the country in which they live, and so as many as 3.2 million unsafe abortions occurred in adolescence in 2008. The other challenge with the unmet need for contraception and the unmet need for SRH services is that it leads to poor PMTCT outcomes in this population. And there was some interesting data presented at IAS showing that PMTCT So prophylaxis uptake is much lower in 15 to 19-year-olds and 20 to 24-year-olds, and that HIV transmission rates are much higher in this age group. So SRH services really do have implications for HIV prevention. So how do we understand this and put it all together, and how does it help us to think about the interventions that we need to develop? Well, this is a slide that you may or may not have seen presented at IAS, and it comes from the EHPSA team, who have done some work using phylogenetic analyses to try and understand where young women were becoming infected from. And what they have done is created this very nice image which helps us to understand the dynamics and the importance of prevention in young women, but also in their partners. So what they found is that young women acquire their HIV infection from men who are a little bit older than them. The initial data said about 8 years. I think that age band has shrunk slightly. And they acquire infection at a very young age, at about 18 years of age. And so they are infected with HIV for a very long time. And if they don't access testing until they're pregnant, they may be infectious to their sexual partners during that entire period. They will then be identified probably during antenatal testing when they have their first child, and will potentially get access to treatment. But during that period, they will have infected potentially their male partners. Those male partners, the EHPSA team identified, are also having young partners, and that is how the HIV epidemic and transmission dynamics are being maintained in these high transmission and high intensity transmission areas. So if we are to intervene, we need to prevent infection in young women. We need to make sure that women who are infected are on antiretrovirals so that they do not pass infection on either to their children or their partners. And we also need to engage with men who are infected in order to encourage them to test and initiate treatment. And so this has led the UNAIDS to articulate 5 prevention pillars aimed at achieving this target of reducing HIV incidence to 500,000 infections by 2020, which is a 75% reduction in HIV incidence. And it's a very ambitious target, but the idea is if we don't do something now, we may never be able to control the HIV epidemic. So this is a very important window of intervention. And the pillars that have been identified are to make sure that 90% of people at risk for HIV infection access comprehensive prevention services, including harm reduction, that key populations have access to a package of interventions, that we expand access to condoms, that we scale up voluntary medical male circumcision, and interestingly, that 3 million people at highest risk for HIV infection are provided with PrEP. Now, in terms of young women and adolescent girls, the recommendations are that there are interventions that should involve economic empowerment, comprehensive sexuality education, interventions to reduce gender-based violence. I'm not going to talk about them much more. What I want to talk to you a little bit about is PrEP, and use PrEP as a case study for thinking about how we think about a prevention cascade. So for those of you who are unfamiliar with PrEP, the key evidence that PrEP is effective comes from 12 randomized controlled trials that were conducted in different populations worldwide. And PrEP was effective in a meta-analysis in reducing HIV risk across age, gender, regimen, and mode of acquiring HIV. And importantly, the rates of adverse events didn't differ between the PrEP groups and those receiving placebo, and resistance was low. So it led the WHO to make the recommendation that PrEP should be offered to people at substantial risk for HIV infection, and that it was safe and effective to use. So part of the discussion has been who is going to benefit from PrEP, and it's believed based on mathematical modeling that the greatest impact and cost effectiveness will be in populations where the incidence is above 3%. And that is really, the mathematical modeling suggests that that would be the general population in South Africa, but otherwise it would be restricted to particular population groups or geographical areas in other parts of the region. And some additional modeling work that was presented by Linda Gale and colleagues at IAS argued that if we were to target PrEP at the 15 to 19 year age group, we would see benefit. And also if we targeted specific locations in country, we may see benefit. But importantly, in our setting, adolescent girls and young women are a key population and would benefit from PrEP. And some of the modeling for the PrEP investment case in South Africa suggested that it would be as cost-effective as immediate treatment. But the Achilles heel of the current PrEP regimens is that effectiveness depends on adherence. And importantly, for us, if with this expensive intervention, what we don't want is to be doling it out like Smarties and people don't use it and then we don't see the benefit. So it's incredibly important that we're able to identify people who are going to benefit the most but who are also going to be able to use PrEP. And we know from the trials of PrEP that there are a number of factors, in fact the same or similar factors that shape HIV risk that also shape people's ability, particularly young women's ability to use PrEP. So things like ART stigma, things like partner violence are all factors that also have been seen to influence adherence to PrEP. And so it's helpful as we think about how we try to design prevention programs for young people. It's useful to begin to think of a prevention cascade and to use PrEP as an example to help us think through the prevention cascade. Now, the treatment cascade has been very helpful for identifying what are where the attrition is in the treatment cascade and what we need to do to achieve viral suppression. And so several people have started to think about what a prevention cascade looks like. Importantly for a prevention cascade, the prevention cascade is trying to conceptualize if we're to take interventions to scale, and if we're to achieve sufficient coverage, what are the key parameters to pay attention to? And those key parameters are to create demand, so to help people to assess their risk and to accept prevention interventions, to focus on supply, so making sure that people have access to prevention interventions, and then ensuring effective use of those interventions. And here are two graphs that try to articulate that cascade, one from a client's perspective, where a proportion of them will not the red bar at the bottom is the product efficacy. And this is kind of taking the whole population and saying, in a population, some people may identify themselves at risk. Some people who are at risk may take up the product. Some people who use the product may use it effectively. And so this is how we derive the red bar, which is what the actual efficacy or the ability to prevent HIV infection would be. And the other graph looks at it from an intervention perspective. So this approach is very helpful for thinking about what is it that we need to do to ensure that we can achieve the prevention efficacy of that product. For example, PrEP. If we really think it's going to be 80% effective when used well, what do we have to do in terms of creating demand, supporting supply, and ensuring effective use? And so the current PrEP programs, the coverage is 2%. So we have a long way to go to achieve the 3 million that we need to by 2020. And there are a number of important questions that the field faces in terms of how do we create demand for this particular product. But one could apply the same thinking to how do we create demand for HIV counseling and testing? How do we create demand for condoms in a young population? How do we support supply? So how do we identify those at highest risk? What services are needed? Do we need to integrate services with other services, for example, sexual and reproductive health, or mental health services, or violence prevention services? And what does adherence support look like? So for PrEP, people are looking at counseling, SMS reminders, drug level feedback, and what do we do to develop differentiated models of care? So the next steps are really to use PrEP as an example for how to understand the adoption of HIV biomedical prevention in young women. and to learn from the early adopters how we can support larger scale uptake of PrEP. But the notion of PrEP is really just an example. I think we can look at the many other interventions and use this cascade to help us understand where there might be attrition in the cascade and what interventions we need to design to maximize the effectiveness of a product. One way to improve adherence to HIV prevention is to develop biomedical tools that remove the need for as intense daily adherence. And so there are a number of new products that are under development or in trials and where we will see results in the next 5 years. We already have data on intravaginal rings, which were shown to be 30% effective in 2 trials. And there are open label extension studies and studies specifically involving adolescents who didn't adhere very well to the ring to see whether what support they need in open label studies when it comes to using this product. There are long-acting injectables. There are phase 2 trials underway, and we expect phase 3 trials to start of at least one of the products mid next year. The idea of broadly neutralizing monoclonal antibodies, it sounds quite science fiction, but there is a trial of infusions of antibodies with the idea of learning about what level of antibody response we need to prevent HIV infection. But also this concept could be commercialized at a later date and may become another injectable prevention modality. And then, of course, there are a number of prevention vaccine trials which are about to start this year. So that is the whistle-stop tour of prevention, but it wouldn't be complete without a brief commentary about treatment in adolescence. And this is a summary of the treatment cascade in Eastern and Southern Africa for adults above the age of 15 years of age. But importantly, there's data emerging that says that with adolescents we see lower rates of testing, linkage to care, and viral suppression, and really need to pay attention to getting young people onto treatment and through the cascade. Importantly, because we haven't had age disaggregated data, we've not been able to understand what the impact of HIV is on adolescents. And so increasingly, we're going to need to put resources into monitoring of programs, both for prevention and for treatment. So at IAS, there are a number of interventions that were articulated that were aimed to support treatment goals. And I've just made a list of them, but importantly, there are goals to optimize and simplify treatment regimens, the importance of point-of-care tests for viral load monitoring and self-testing for HIV, looking at incentives for testing, linkage to care, and adherence, mHealth interventions that would provide reminders for visits or adherence, differentiated models of care that allow for care in communities, integrated care, important talk about models of transition to adult care and not losing young people to treatment then. And you heard already the importance of stakeholder involvement and empowerment of young people. And this was an incredibly powerful theme during IAS, which is where young people stood up and articulated what it was that they needed from treatment programs. So in conclusion, I would say that the treatment and prevention landscape for HIV is rapidly changing, particularly when it comes to adolescents. And it's very clear that we're going to need significant investment in HIV prevention if we're going to achieve the UNAIDS goals. These programs need to be targeted at those most at risk, and to do that we need to understand the drivers of infection. We do have evidence for interventions, but the challenge really is taking them to scale and understanding how to take them to scale and achieve optimal coverage. And cascades, both for treatment and now for prevention, are going to be useful for analyzing the barriers to delivery and designing of interventions. Thanks very much.